This program is presented by University of California Television. Like what you learn? Visit our website or follow us on Facebook and Twitter to keep up with the latest UCTV programs.
Tonight, I've got the pleasure of talking about fibrodysplasia ossificans progressiva, and I'm just going to say FOP for the rest of the talk. It's a very rare disease, and I'm going to describe it in detail. But before we get started, I want to mention, I'll talk some about the research into the disease. But before I get into the body of the talk, I just want to mention that the research going on FOP doesn't affect just people with FOP. It has strong implications for many other diseases, including those where there's other episodes of heterotopic ossification, which means bone formation in the wrong place. And some of those conditions are brain and spinal cord injuries, athletic injuries, peripheral nerve injuries, burns, war injuries, blast injuries, total joint replacement, particularly total hip replacement, valvular heart disease and atherosclerosis. All of these conditions may have heterotopic bone complicating the problem. In addition, it has implications for conditions where we want bone to grow. For instance, if facial deformities or if there's cancer where part of a jaw is removed, can we get a new jaw to grow? So this research, although it's directed towards FOP, it has broad implications. So I'd like to start off with two questions. First of all, what is FOP? It's a rare, debilitating genetic condition in which the skeletal muscles, the tendons, and the ligaments progressively and permanently turn into bone. It's just where the tissues actually change into bone. Almost all the cases are new mutations, and that is there are very few multi-generational families with FOP. In fact, there are only 7 families known in the world that are multi-generational. There are 2 classical features, and you're going to hear this several times during the talk. Distinctive malformations, sorry, I've got a bit of a shake that's developed. Distinctive malformations of the great toes. They're short with a lateral deviation, and the medical term for that is hallux valgus. And there are episodic flare-ups where the individual develops tumor-like masses that appear very rapidly. They may appear in a few hours or overnight, and they progress to ossification, to bone formation. And most importantly, we currently have no effective treatment. And even worse, most cases are initially given incorrect diagnoses, and there are complications from inappropriate medical interventions because of the misdiagnoses. Now, this slide shows the malformations of the great toes. They're short, they're deviated laterally, or a valgus deviation. And this is an example of a flare-up, this mass on the back of this child. They're tender, they're warm, and they're red. It's hard to appreciate that this is red, but they actually become red in a classic flare-up. So the second question is, why is an old retired neonatologist talking about a rare bone disease that almost is never diagnosed before age 3 years? And the reason is this little boy, Matt, our grandson. This picture's from several years ago, as you'll see. Matt was born at term with short, great toes. And the pediatrician asked his parents, whose toes does he have, mom's or dad's? And the answer was neither. He developed normally. He played Little League baseball. In high school, he went out for the football team but quit because he didn't enjoy it. His father and uncles have a speedboat, and Matt became an avid wakeboarder and became quite good at it. At age 17, he fell while wakeboarding, and he felt a pain in his neck and said he was somewhat stunned. And shortly thereafter, he developed, or a mass developed on his back. He was taken to his pediatrician. The pediatrician said, I think you should see an oncologist. So he went to a pediatric oncologist. And as oncologists are wont to do, a biopsy was done. He was presented to the tumor board here. And the initial diagnosis was a probable lymphoma. Lymphoma is a solid tumor, cancer of white blood cells, of lymphocytes. But it wasn't typical. It wasn't a typical microscopic appearance. So it was recommended that a second biopsy be done. And that came back aggressive fibromatosis. And this is another very rare disease that's not cancer, but it's locally invasive. And the treatment for this is chemotherapy. So Matt was given chemotherapy, and as often happens with chemotherapy, he lost his hair, and you can imagine how upsetting that is to a 17-year-old. And after the course of chemotherapy, his oncologist ordered a CT scan to see how the tumor responded to the chemotherapy. The radiologist called and said, you put the wrong name on the requisition. And the oncologist said, no, it's the right name, it's Matt, it's who it is. And he says, well, then your patient has FOP. And the oncologist said, what is FOP? And the radiologist described it to him. The oncologist then called me and said, Matt has FOP. And I said, what's FOP? I'd never heard of it. So anyway, we learned a lot about it. Matt learned a lot about it. The whole family learned a great deal about FOP. Now, this is a picture about 7 years after he was diagnosed. And this is Dr. Fred Kaplan from Philadelphia, and you'll hear more about him. He's not down on the floor because he's had too much wine. He's got down to the floor so he can look Matt in the eye while he talks to him. You see Matt's knees are flexed partially. It's hard to tell in this picture, but his hip is flexed partially, and his back is bent over and is rigid, so he can't look straight ahead. So Dr. Kaplan wants to look him in the eye while he talks to him. Now, last week, with Matt's permission, I took a video of him walking, and you'll see how his FOP has affected how he's walked. And I might tell you now that he's actually very lucky. He's 32, and he's still able to live independently. He drives. He's working on getting his bachelor's degree. He has an associate of arts degree. But I think you'll be impressed with how it's affected his walking. This was taken last week, and notice that his knees don't straighten out, his legs don't straighten out, his hips remain bent, and his arms don't swing freely as he walks. They're quite restricted in movement. Yeah, I'm sorry about the quality of that, but I think you get the gist of the problem. Okay, FOP is not a new disease, even though there's often misdiagnoses. First description was in France by Guy Patin, who described a woman who gradually became hard like wood. And there were 3 cases described in letters to the Royal Society in the 1700s. There were intermittent reports in the literature, and in 1918, Julius Rosenstern at Mount Zion Hospital here in San Francisco reported a case and reviewed 120 cases from the literature. So it's well described in the literature, although not very frequently. And this is a graph of the number of articles in the medical literature, according to the National Library of Medicine, that are about FOP over about the last 30 years. Excuse me. And you can see that there was between 5 and 10 a year appeared until the mid-90s when there was this big spike. And this was due to research and clinical work done at the University of Pennsylvania when Dr. Kaplan got into FOP. And I'm going to talk more about that. But that was mostly clinical work, reports describing the disease in more detail. And then in 2006, Kaplan and his associates reported the gene responsible for FOP. And following that, there's been this enormous productivity of papers regarding FOP. And they're not only clinical papers, but very hard basic science. And we're gonna, I was advised not to speak heavily about basic science tonight, but I will touch about research, what's going on towards the end of the talk. But this is really the result of the gene being discovered. Now here's Dr. Kaplan. This is in Yosemite. He's an orthopedic surgeon. He's director of the Center for Research in FOP and Related Disorders, which is generally people refer to it as his FOP lab, which he doesn't like. He wants it the formal name. He trained at, he went to undergraduate and graduate and medical school at Johns Hopkins, and then went to the University of Pennsylvania for his orthopedic training. And he's trained as an orthopedic surgeon. And in 1989, Mike Zasloff, who's a pediatric geneticist who was at Penn at the time, said, Fred, have you ever seen a child with FOP? And he says, no, I've seen adults with FOP. He said, come to me to clinic today and see a child. And he did. And it changed Fred's life. He became, oh, I'm sorry, got to tell you one more thing. The co-chair with Dr. Singh of this series is Jeff Tavis, who's in emergency medicine also. But at that time, he was a medical student in the lab doing an elective with Dr. Kaplan. And Fred went to Jeff and he said, Jeff, can you tell me about genetics? He says, what's an intron? What's an exon? What's a codon? And Jeff said, no, Dr. Kaplan, it's too complicated. I just can't tell you. You've got to study it. So Fred became a research fellow in Mike Zasloff's lab for 2 years. And he has since devoted his career to FOP. Not only research, but care of patients worldwide. He doesn't do orthopedic surgery anymore. He occasionally will see a few patients with other conditions, but otherwise it's all FOP. He's won numerous awards. He's made enormous advances. And Newsweek described him in 2006 as one of the 15 people who make America great. And almost all of the advances that I'm going to discuss tonight have been done by Dr. Kaplan, his associates in that lab, or colleagues from other universities in collaboration with him. So I'm going to go a little more detail about FOP clinically. The malformations of the great toes I mentioned, and these episodic flare-ups that lead to progressive heterotopic ossification, bone formation in the wrong place. It's very rare. It's one of the rarest diseases that affects humans, 1 in 2 million. So there should be about 3,500 in the world. I'll talk later about the International FOP Association, but they are aware of 800 people in the world, about 800 who have the condition. There are probably a lot in Russia and China that have not been diagnosed that we don't know about. But the incidence is the same. It's equal in males and females. There's no difference by race, ethnicity, or geographic location. So it's quite an interesting disease. It's the inheritance, as far as it can be told, is an autosomal dominant. And what that means is it's on an autosome. The gene is on an autosome, not one of the 2 sex chromosomes. It's actually on the chromosome number 2. It has 100% penetrance, which means if you have the gene, you have the disease. But it's got variable expressivity, and that is, it might be very mild or it might be very severe. Matt is quite unusual in that he didn't have symptoms until he was 17. Almost all cases, or almost all people with FOP have their onset of their symptoms, their flare-ups, in the first decade of life, and usually by 3 years of age. And there was a recent case reported where a man did not have symptoms until he was in his 40s, although he definitely has classical FOP. There's progressive and permanent loss of mobility due to the heterotopic bone formation affecting joints. And the cause is what's called an activating mutation of a type 1 bone morphogenetic protein receptor known as ACVR1, and I'll describe this in more detail. But this is what was discovered and reported in 2006 by Kaplan's laboratory. And once again, there's currently no effective treatment. Now, the bone malformation, the toe malformations are present at birth. This is the footprint, neonatal footprint of a baby girl in Santa Maria. You can see that. And notice that the great toes are quite short. This is her at a couple of years of age, so the short great toes. And here she is at 19 years of age. And you'll hear more about her. She's actually currently in hospital here. This is the picture you already saw, and this is an X-ray of an individual, of the feet of an individual with FOP. Now, the great toe is like the thumb. There are only two small bones in it, or phalanges. All the other fingers and toes have 3 bones, 3 phalanges. In this individual with FOP, you can see there's only 1 bone here. This is the metatarsal, and this is the single phalanx in the toe. The toe is short because there's either an absent phalanx or it's very hypoplastic or small. The flare-ups most commonly occur centrally and towards the head. First on the back, the head, the neck, or shoulders. And here are examples. Here's this child was about 1 year old when he developed this mass. This is a little Swedish boy. Developed this mass on the back of his head. Here's an individual with a mass on the back and another little child with a mass here. These appear very rapidly, over hours, I mentioned, or overnight. And when the parents bring the child into the doctor, unless the doctor knows about FOP, and until recently, I would say most people did not know about FOP. Most doctors do not know about FOP. They wouldn't believe the parents. You know, that mass could not have come this quickly because cancer doesn't arise that quickly. There is one cancer, a rare cancer called Burkitt's lymphoma, which can appear in several hours. But in general, cancers don't appear that fast. These are microscopic pictures of flare-ups, and I'll tell you in a few minutes that biopsies should not be done. They're contraindicated because they're traumatic in FOP because they stimulate bone formation. But these biopsies were done before the diagnosis was made, and they're useful in showing the progression of the lesions. The initial microscopic lesion is infiltration of small white cells, lymphocytes, around blood vessels, perivascular infiltration. These cells are striated muscle, skeletal voluntary muscle cells, and these are the nuclei of the muscle cells. The lymphocytes then spread out through the muscle, and then the muscle starts to degenerate. Fibrous tissue starts to form, thus the name fibrodysplasia. Then it turns into cartilage and subsequently into bone. And this is a normal process of endochondral ossification, that is, bone forming from cartilage. The process is normal. What's wrong? The thing that's wrong is it's in the wrong place at the wrong time. This paper was by Kaplan and Tabus. This is one of the 5 or 6 papers that Jeff Tabus, I mentioned earlier, was either authored or co-authored from being a medical student in Dr. Kaplan's lab. So the bone is normal if you look at it under the microscope histologically. If you analyze it for its contents, it's normal biochemically. Metabolic processes are normal. The physical characteristics are normal, and it appears to be normal on X-ray. What's abnormal is what I said before. It's in the wrong time and the wrong places. So it affects striated muscle, voluntary muscle. It affects ligaments, tendons, and fasciae, or broad sheets of fibrous tissue. It's interesting that it spares the respiratory diaphragm. It spares the tongue. It spares the extraocular muscles. It spares the tongue, but does not spare the throat. The muscles of the throat can be involved, so that swallowing can become a serious problem. And it usually spares the small muscles of the hand. Cardiac muscle and smooth muscle are not affected. There are different types of muscle, from skeletal or voluntary muscle, so they're not affected by FOP, but all the other muscles are. And there's a characteristic progression. I mentioned it's first in the head, shoulders, back or neck. So it's up towards the head and then moves down caudally, or towards the lower part of the body. And it's axial to peripheral. In other words, it involves the spine first, and then gradually will move out to the extremities. And this is very typical, but the rate of progression, the rate of flare-ups varies greatly from individual to individual, and varies greatly in an individual. A person may have several flare-ups in a year, and then may go a few years without any flare-ups. There can also be bone formation without these flare-ups, so there can be progression without obvious clinical flare-ups. So the clinical aspects. Toe malformations are present at birth. Usually in the first decade of life they have symptoms, and it's usually misdiagnosed initially. And I'm going to talk in more detail about the misdiagnosis. The flare-ups can be spontaneous. They can be triggered by trauma, falls, biopsies, intramuscular injections, and surgery. And they can also be a result of viral infection. And if you attempt to remove FOP bone by surgery, you really cause problems. And not only will it come back quickly, but it will lead to bone formation, rapid bone formation in other parts of the body. At a recent meeting a few years ago, I was speaking to a mother of a teenager with FOP, and he had a bone that went from his pelvis down to his mid-femur. And he was misdiagnosed, and so they surgically removed it. And the mother claims, and I have no reason to doubt her, she said within a week that bone was back again. Well, it probably wasn't fully ossified, but there was a structure there that prevented him moving his legs. So it's a very rapid process. The earliest patient I know that had a flare-up was a baby born by cesarean section, and when the obstetrician did the cesarean section, the scalpel partially cut the baby's scalp, and got a big bone formation there, and then went on to have FOP. But usually it's not in the neonatal period. These are examples of FOP, that's pictures of people with FOP where there's been several flare-ups, and you can see episodes. These arrows point to heterotopic bone. This man's from Morocco and has extensive heterotopic bone on his back, and you can see at least 3 scars, and I think there are 4 scars from attempts to remove the bone before FOP was diagnosed. And this is quite a dramatic picture of heterotopic bone in a young man with FOP, and you can see that this big strand of bone here has other bone formed. And notice that he has a curvature of his spine. When there's the bone, if it connects spine to ribs or pelvis to ribs, will not allow growth, so that as the spine continues to grow, the body will curve, the spine will curve, and the person will develop what's known as a scoliosis. There's also spinal fusion that's spontaneous. The vertebral bodies are taller than normal, and they tend to fuse spontaneously without flare-ups, so that the spine becomes rigid. It may be straight, or it may be curved over, and I'll show you examples of people with FOP both have curved over backs and who have straight backs, but they're all rigid. By the time they get to be in their late teens or 20s, they have rigid fused spines. And a frequent place where bone forms early is what's called the nuchal ligament, which just runs from the back of the head down the spine. And quite often that will be ossified, not calcified, but ossified very early. So these heterotopic bones lead to progressive and permanent loss of range of motion and thus mobility. This is a 3D, these pictures are a 3D reconstruction of a CT scan of an 11-year-old boy with extensive heterotopic bone. You can see these long ribbons of bone connecting his pelvis up to his chest, back up his spine, over this side of the rib cage. Here you can see the scapula is involved and fixed to the rib cage. There's other heterotopic bone there, but the most dramatic here is in the spine. And this, I mentioned the nuchal ligament. This is an ossified nuchal ligament. That's an early finding. The best known individual with FOP was Harry Eastlack, who you can see his born and died. Here's his neonatal footprint. You can see the short great toe. Here he is at age 4 years. Looks pretty normal. By 7 years, he's asymmetric. By 9 years, he's bent over. By 11 years, it's worse. And 18 years, it's quite marked. His head is down. He died when he was 37. And this is his skeleton. He willed his body for medical research, and his skeleton is in the, pardon my German pronunciation, but I think it's pronounced Mutte Museum in Philadelphia. And Harry's skeleton is brought to FOP meetings, so everyone can see this, the people who are at the meetings. This is a very severe deformity in FOP. This girl developed ossification of her sternocleidomastoid muscle, which is the muscle that runs from up here down to the sternum and the clavicle. And that ossified very early, and as her spine grew, that bone did not grow, and gradually her head tilted down onto her chest. Now, I mentioned earlier that surgery is contraindicated to remove the bone. There's a great deal, this little girl's from Philadelphia, and there was a great deal of discussion with Dr. Kaplan and other orthopedists, and whether or not they should try to do anything, or would they make her worse. And after a lot of agonizing meetings, they decided to go ahead and try to straighten out her neck, and they did. And the concern with doing surgery is you're going to produce more bone formation. So they did the surgery. They straightened out her spine. They cut the sternocleidomastoid muscle and straightened out her neck so it was pretty straight. And then they packed her spine with bone that they took, for instance, out of the sternocleidomastoid, with the idea of fusing the neck straight, and that happened. And in follow-up, she said she was quite happy with the results. He wasn't looking at the world upside down and terribly restricted like this. Now, there are other features of FOP other than just the bone and muscle involvement. About 50% have mild hearing loss. And the original thought was this is probably what's called conductive hearing loss. The sound comes to the eardrum, which vibrates and moves the three little ossicles in the middle ear, which are controlled by skeletal muscle. And then they generate vibrations in the cochlea, which stimulate the hair cells where you can hear, where the brain senses the hearing. It was originally thought that this is probably due to bone formation in these tiny muscles, but it may be that it's actually a neurological complication of FOP. There are now recognized neurologic complications. There's an increased incidence of headaches, not necessarily migraines. Migraines seem to appear with the same frequency as in the general population. There's neuropathic pain that's a markedly increased incidence. And neuropathic pain is pain that has no obvious traumatic cause. It's just the patient develops pain in an area, and it's something apparently in the brain or in the nerve that generates the pain. There are sensory abnormalities, and they're most common in the legs and feet or the hands and arms, and they include tingling, pins and needles, sensations of cold or sensations of very hot, and sometimes the people who have very hot extremities, they'll say, my feet turn bright red. In fact, they do. It's quite dramatic. Myoclonus is a shaking frequency that's slower than a tremor. The incidence of myoclonus in the general population is about 1 in 300,000. So it's pretty rare. A rare form of myoclonus is what's called propriospinal myoclonus. And in my mind, that's similar to a seizure. It's when there's an abnormal electrical generating focus somewhere in the spine, and the abnormal electrical impulses go both up the spine and down the spine. And it's sort of like a seizure in the brain. It's like a brain seizure, but it's only in the spinal cord. In this study we did, there were 3 individuals with myoclonus. 2 had propriospinal myoclonus. And if you have 2 conditions that are rare, you multiply the frequency of each one together, and it will give you the likelihood of an individual having that. Well, if you have a condition that occurs 1 in 2 million, and another condition that occurs less than 1 in 300,000, and you multiply those together, you've got an enormous odds against those 2 occurring by chance. There are 2 young women with propriospinal myoclonus, and another individual with myoclonus, and it's very likely that their FOP and propriospinal myoclonus are associated. And we also know now that there are demyelinating lesions of the central nervous system. Myelin is the fatty tissue that makes the white matter. It covers the axons, and so it helps speed transmission of nerve impulses. And there are several individuals with FOP where demyelinating lesions, what they appear to be demyelinating lesions on MRI. And in the same study, Lishan Khan at Northwestern used 2 different mice models of FOP. And I'll discuss those mice models in a little while. But what he found is they had similar lesions on MRI, and when he examined them microscopically, they in fact were demyelinating lesions. So there's something about FOP that will affect the brain and spinal cord. We know that there's a mouse model that's in the FOP community is called the FOP mouse. It's a mouse that overexpresses bone morphogenetic protein 4. It's a transgenic mouse model. And this was done also at Northwestern University. And surprisingly, or to the surprise of the investigator, they were investigating bone morphogenetic proteins, and what they found was that these mice developed heterotopic ossification that looked like FOP. So they studied it, and in fact, these mice do have lesions in the brain. They also found that there was a decrease in the formation of certain nerve cells or brain cells during development of these mice, oligodendrocytes, which produce the myelin of the brain that covers the nerves, and they were decreased during development. So we don't know whether that's true in humans. This is not a true genetic model of FOP, but it has certain similarities. But it may explain why there are these neurologic complications of FOP. And recently, a study was done of a large number of 55 individuals with FOP, and it was found that about 20% have a rather typical facial pattern that includes mildly receding jaw and underdevelopment of the mid-facial area. And if you go to a meeting where there are a lot of people with FOP, you can see that there is a typical facial pattern. Oh, I'm sorry, I forgot to mention this, the asterisk. These increased symptoms, these neurologic symptoms, were present only in post-pubertal females. The incidence of the all these conditions in males and in prepubertal females was normal, same as the general population. The other thing that's interesting is that the females, the post-pubertal females, 33% reported that their neurologic symptoms got worse during their menstrual periods. So clearly there's a hormonal component of this, and this is totally unknown. You know, I forgot to say something earlier. I meant to say the subtitle of this series is called Inside the Mind of Great Physicians, and the great physician for this talk is Fred Kaplan. I meant to say that when I was talking about him. Remarkable, remarkable man. Okay, if it's such a rare disease, who's going to see, what physician has 2 million patients that he's going to see a patient with FOP? Well, in the last 13 years, these are the patients that have been seen here. 2000, a 17-year-old male with masses on his neck, back, and chest presented at Pediatric Tumor Board. That's our grandson. In 2003, a 3-year-old male with neck masses. This is interesting. I'm going to talk to you about another young man with FOP, who's one of his grammar school teacher's sister worked in the intensive care nursery. And in 2000, when I was still working as a neonatologist, when Matt was diagnosed with FOP, we invited Dr. Kaplan out here to see Matt, and he also spoke at pediatric grand rounds. This nurse practitioner in the intensive care nursery came to Dr. Kaplan's talk because she knew that her sister had a student in her class who had FOP in Fresno. So she came and heard his lecture. And then several months later, she was at neonatology, the intensive care nursery X-ray conference. And as they were finishing, she overheard one of the oncologists speaking to one of the other radiologists talking about this little boy with a mass on his neck, and where were they going to do the deep biopsies, because they'd done some superficial biopsies and they couldn't make a diagnosis. And the nurse practitioner interrupted, and she said, "Excuse me, does this little boy have abnormal toes?" And the oncologist says, "Yeah, why do you ask?" She says, "Well, he might have FOP. I can't remember what it stands for, but you could call Joe Kitterman or call Fred Kaplan at Penn." And then she called me. Anyway, it turned out this little boy did have FOP. She saved him from having additional biopsies. 17-year-old male, seen in orthopedics clinic. 23-year-old female, she came into medicine with severe flare-up of her arm. Her arm was about 3 times normal size, and that gradually resolved. 18-month-old male, also from the Fresno area, admitted to pediatrics with a stiff neck and masses over the neck, back, and forehead. 29-year-old female from Sweden. She came to the U.S. to go to an FOP conference in Florida, and she and her husband took the opportunity to go to Yosemite since they were coming to the United States. The car they rented as they were coming out of Yosemite lost its brakes, and she was in a severe auto accident. She was hospitalized here for a couple of weeks, and then the Karolinska Hospital in Stockholm flew a doctor and a nurse out here, and they flew her back to Sweden. And then 2007, 2013, this young woman who's been admitted 28 times to pediatrics, and she's now here with her 29th admission, and these are all for neurologic complications. She's one of the people I mentioned with propriospinal myoclonus. She has terrible migraine headaches. She's been tried on many, many different drugs, and we've consulted physicians not only here, more than 60 physicians at UCSF have consulted on her, but physicians across the United States and actually internationally. She's been a very difficult diagnostic and therapeutic problem. This is a picture of the attendees at an FOP meeting in San Diego in 2009. There's two reasons I want to show you this picture. There's a marked variation in the severity of the disease. These are all young people between about 14 and 28. This young lady, this young lady, this young lady, and this young lady are all within a couple of years of each other. And if you see her, she looks fine. She doesn't look like she has FOP. She's very mildly affected. This young lady is more severely affected. This one is wheelchair bound, and this one has been wheelchair bound since she was about 10 years old and is very severely affected. And all she can do is move her hands about that much. She can write if you move the paper while she moves her hand. So this is, when we talk about variable expressivity, this is variable expression of the same disease. This is Matt back here. This young lady looks like there's something wrong with her shoulder, and we'll talk more about her. She doesn't have a shoulder there. And this is the young man whose teacher's sister came to the lecture about FOP. He is the first individual with FOP to attend medical school, and he's currently a second-year resident in pediatrics at the UCSF Fresno program. And you can see that he looks relatively mildly affected. His arms are restricted, and since this picture was taken, he's bent over a little bit more and he's having more trouble walking. But he was able to get through medical school, and he's now in his second year of residency. Several of the people in the picture are either college students or have graduated from college, including Sarah. She's graduated from college. This fellow is works as an accountant for several hospitals in Pennsylvania. The other thing I wanted to show you, want you to look at in the picture, is the expressions on their faces. Almost all of them are smiling. And this is another thing I don't understand. Yeah, you smile for a picture. But people with FOP seem to have a remarkably positive outlook on life. And it's a pretty tough disease to have. And why they're so positive, I don't know. We have no idea whether or not it's an effect of FOP on the brain, such as, we know that FOP affects the brain and spinal cord. Could it have other more subtle effects? We have no idea. Certainly with certain conditions, there are mood changes. For instance, multiple sclerosis is associated with either euphoria or depression, most commonly euphoria, but often depression. Does FOP have an effect like that on the brain? We have no idea. But it's quite remarkable how positive almost all of these people are in their outlook towards life. Okay, I mentioned most of the patients are misdiagnosed. In 2000, after Matt had been diagnosed, Matt, my wife, and I went to the Third International Symposium of FOP in Philadelphia, and the thing there were about 80 to 100 people with FOP at the meeting from around the world. And in talking to the people, the thing that struck me the most was the stories of misdiagnosis and problems they had. So we did a study where we sent out questionnaires to all the known cases in the world and got 138 replies from 25 countries. And it was dramatic that 87% were initially received incorrect diagnoses. Now, if you're familiar at all with medical legal aspects, the standard of care is what goes on in the community. So the standard of care for FOP is misdiagnosis. It's not a very good commentary on our clinical medicine here and throughout the world. Oh, and I might mention that the frequency of misdiagnosis was the same in the United States as the rest of the world. Average of 6 physicians were seen before the correct diagnosis. One person in this study diagnosed himself from a television show, and he'd seen many physicians. Most common misdiagnosis was cancer, 32%, most commonly lymphoma, fibromatosis, I mentioned earlier, aggressive fibromatosis, and desmoid tumors, which are similar, they're a fibrous tissue. Bunions, I've never heard of neonatal bunions, but people have been diagnosed with bunions as newborns who have FOP. And hallux valgus is not a diagnosis, it's a description of the malformation of the toe, and yet that was a diagnosis. Overuse injuries, for instance, you've been doing too much athletics, it's the problem. And there were 43 other misdiagnoses, I should say, among these patients. I mentioned that biopsies cause trauma and cause bone formation. 67% underwent biopsies, and 49% of the group reported that they had permanent loss of function because of inappropriate medical intervention. And that most commonly was surgery, either on the toes or surgery to correct a malformation of the wrist because bone had moved the wrist. One mother in this study wrote in and said, I don't know why we kept doing it, but we kept listening to the doctors, and we were wrong and they were wrong. And he went on and on. There's some really quite dramatic comments that were made about the misdiagnosis and the inappropriate medical care. And this is the most egregious case of misdiagnosis. This is the young girl I pointed out in the other picture. When she was 3, she had developed a mass on her right shoulder, was diagnosed as cancer, and they did, the doctors did what was called a 4-quarter amputation, where they took off her right arm and shoulder, and after the surgery, they made the diagnosis of FOP. She's a remarkable young woman. Her mother is a remarkable person. And this young lady married a remarkable guy. You can see she has a wedding ring on, and she got married when she was in her 20s. The first international symposium on FOP was in 1991, and Ashley drew a picture for this. And I don't know if you can read that, but it says, "Save the FOP children." And notice there's no right arm in this drawing. And we wondered, why don't doctors know about FOP? Why didn't I know about FOP? It's not, if you think about it, here's this condition with very abnormal great toes that are easy to see, and they develop these tumors. Well, it's something, it should stand out. You should learn about it. You'll never forget it. You'll never see anyone with FOP, but you'll never forget what you learn. And what we did was we looked at a bunch of textbooks, 184 textbooks, to look how many did we look at, how many even mentioned FOP, how many mentioned the great toe abnormalities, and how many mentioned that trauma made things worse. And it's the ones in red are pediatric textbooks. And what's striking to me is we also looked at podiatric textbooks, and a very small number mentioned FOP, which was quite surprising to me. Pediatrics is quite shocking. Neonatology, of 8 textbooks of neonatology, none mentioned it. That's changed now. There's at least one that mentions it and has a very good session on it. Pediatric oncology, most people with FOP are misdiagnosed with cancer, and yet only 1 of 14 pediatric oncology textbooks even mentions FOP. So our conclusion, or maybe our assumption was that the lack of FOP information in medical textbooks leads to lack of knowledge among physicians. I think this has changed a great deal. There's been many more articles about FOP, and there have been several television shows about FOP, including one about Matt that was on, I can't remember the name of the, what was the name of the series? I'm sorry? Mystery Diagnosis on TV. Matt was on about 3 years ago. So a difficult disease is made worse by lack of knowledge of the disease among physicians and inappropriate intervention. And clinically, it's a very easy disease to diagnose. There's the malformed great toes, there are these masses, and if you have both of those, you have FOP. You can make the diagnosis clinically. You don't have to do anything else. No x-rays, no biopsies, nothing. There is a lab test, there is a blood test that can be done for the gene that's available, I believe, only at the University of Pennsylvania laboratory, but it's not necessary if you know about the disease. Okay, if there's no effective treatment, what do you do for people? If you're a physician and they come in to see you, well, the first thing is make an accurate diagnosis and avoid trauma. Intramuscular injections should not be done. It's particularly a problem with children with immunizations, because some immunizations, they say, have to be given intramuscularly. And another interesting point is, with the first intramuscular injection, they never get bone formation. It's the second or third or fourth. So there's an immunological component of FOP involved here. Biopsies, surgery, falls, and also something that Matt and the lady from Sweden taught me is that fatigue, overdoing things, will lead to flare-ups if they physically overdo things. Muscle relaxants seem to help. There must be a component of muscle spasm involved in FOP. It's not just the bone formation, but muscle relaxants help. Non-steroidal anti-inflammatory drugs for pain relief. And Vioxx was very popular, and people with FOP said that was the most effective non-steroidal anti-inflammatory drug they could take, and then it was banned, and a lot of people are sorry about that. And in this regard, opioids, narcotics, will often make pain worse and make the FOP worse. When flare-ups involve new joints or the airway, the jaw, or the throat, high-dose adrenal corticoids for 3 to 4 days. And high dose, we mean about 2 milligrams per kilogram of prednisone, which is an exceedingly high dose. Adult physicians would never give that kind of dose for some sort of immune reaction or so forth. And then you can repeat it once if flare-up persists, but you don't want to stay on high-dose steroids for very long. There are a lot of complications. More recently, infusions of amino-bisphosphonates may help in flare-ups. Neither the steroids nor the bisphosphonates have been subjected to a controlled trial. And the bisphosphonates, to me, make no sense at all, because they're used for osteoporosis to help calcify the bone more. And yet they seem to, if you start them early in a flare-up in FOP, they seem to abort the flare-up. And again, currently no proven effective treatment, but we'll talk about what's coming down the line. There are 2 other conditions or situations in FOP that bear mentioning, and that is dental procedures. Several people with FOP have permanently locked jaws due to inappropriate medical care. Either mandibular blocks, where an injection is made here to block the entire side of the lower jaw, that will cause ossification of the masseter muscle, and the mouth will never open again. Or If the patient is given general anesthetic, for instance, nitrous oxide, and for procedure, you can't stretch the mouth open to get good access, because that will also damage the muscles and cause permanent locking of the jaw. And some people with FOP with locked jaws will actually have their teeth removed so they can get food in. And general anesthesia, they should never be intubated through the mouth. If they require endotracheal intubation, it should never be done through the mouth, because you put in a laryngoscope to lift up the tongue to visualize the larynx, and you have to stretch things open. Use nasotracheal intubation, and then careful positioning of the patient to avoid pressure trauma, because they may have fixed limbs. You just can't lay the person on a table and expect it to work, a usual OR table. Okay, what's the outcome? Recurrent flare-ups leading to ossification, progressive and permanent loss of mobility, and most are wheelchair-bound by the 3rd decade. Many need assisted care for their basic personal functions because of limitation of their arm movement. Malnutrition, especially after inappropriate dental work. People with FOP often complain about bowel problems, difficulty eating, and pain in their bowel. That's totally unexplored at this point. We don't know what's going on there. Progressive worsening of cardiopulmonary function. They may develop pulmonary hypertension due to restrictive lung disease. Restrictive lung disease is when you can't move your chest as much as normal. The chest wall fuses. They not only, I mentioned they get spinal fusion, but there's an abnormality of the joints, the costovertebral joints, which are the joints between the rib and the spine, and they tend to fuse, so that the chest becomes fixed, and the only breathing is done by the diaphragm, which is not affected. And then the worsening of cardiopulmonary function is development of pulmonary hypertension, which leads to heart failure. And there's a shortened lifespan. A study was done that said that the median age lifespan is 40 years, but a wide range up to 77 years. And this study was done several years ago, and I'm quite sure that with improved care and improved diagnosis, the lifespan is going to be much longer. The main cause of death, cardiorespiratory failure. Way down the line is pneumonia and falls, are about the same incidence. Okay, what is the genetic cause? We'll get into some basic stuff now. I mentioned it was an activating mutation in the gene encoding for the type 1 bone morphogenetic protein receptor ACVR1 or ALK2 on chromosome 2q. That's the long arm of the 2nd chromosome. And the receptor is a protein that sits on the cell and responds to bone morphogenetic protein coming along. It's an identical single molecule change in the 45 individuals studied at the University of Pennsylvania. Once the gene was discovered, the identical same molecule was mutated. This is quite amazing. Cystic fibrosis, there are more than 200 different mutations that cause cystic fibrosis. FOP has the exact same mutation in every individual. And it was absent, this mutation was absent in 159 individuals tested who didn't have FOP, and many of these were family members of people with FOP. So the mutation results in overexpression of messenger RNA for BMP4. And the messenger RNA leaves the nucleus, goes out to the ribosomes, and tells the ribosomes to make a specific protein. There are molecules produced by the cell that regulate BMP and will downregulate the receptor and BMP, and this mutation causes failure to upregulate these antagonists. Ligand-independent BMP signaling, what that means is that the receptor acts as if BMP4 is there, even though there's no BMP4. So it's telling the cell there is BMP4 there. So it's activating mutations. And then if there is BMP4, the cells overreact to it. And normally the receptor that sits on the cell, has an internal and external part on the cell membrane. After a while, receptors are internalized and degraded, and there's decreased removal of these receptors. So all of these things lead to the cells being told there's BMP activity, and it goes on, and bone morphogenetic proteins are the cells that form bone and cause it to grow. Now, I'm briefly going to go through a bunch of very important research advances. I mentioned the FOP mouse that overexpresses BMP4 and has heterotopic ossification like an individual with FOP. This was at Northwestern. The discovery of the FOP gene in 2006 by Kaplan's group. They also found that the cells that cause the flare-up are from the endothelium. The endothelium is the lining of blood vessels. These cells leave the blood vessels and are changed into stem cells. And it may be BMP4 that changes them into stem cells, but that's not known. But these endothelial cells leave the lining of the blood vessels and are converted into stem cells. Stem cells are cells that have the potential to develop into different kinds of cells. In 2011, it was reported that retinoic acid receptor gamma agonists inhibit heterotopic ossification. Retinoic acid has been used previously in a trial to try to treat FOP. The results were mixed, and this is a much more specific thing. And this, what these investigators found was, and these were people in Philadelphia, but at Thomas Jefferson University, not at Penn, that these agonists block bone formation in several models of FOP. The Northwestern group, collaborating with the Penn group, found that substance P, which is a neuroinflammatory modulator, it comes from the nerve cells itself. They cause the cascade that leads to bone morphogenetic protein causing heterotopic ossification. So, and then recently, short interfering RNA molecules can, I should say first that FOP cells have abnormal chemical signaling of bone morphogenetic protein, the whole cascade in the cells, and you can block that with what are called short interfering RNA. And the reason I even mention these complicated things are they raise the potential of ways to treat FOP, either blocking the receptor, using these agonists to inhibit heterotopic ossification, blocking substance P, or possibly changing the signaling within cells. In 2011, there was a scientific workshop at Penn, and you can see the title there. The reason I even mention that is Fred Kaplan has very carefully avoided talking about any sort of treatment over several years, 24 years he's been involved in FOP, because he does not want to give people false hope. But he actually convened this workshop because he thought it's time to start talking about treatment. In 2012, the Penn group reported a transgenic mouse model of FOP. That's a true genetic model, and I'll talk more a little bit about that. And so it raises the question of a clinical trial for treatment of FOP. And this is coming, but I can't tell you what the trial will involve. I don't know. The annual report from Penn on FOP advances suggests that there may be several different methods of treating or attempts to treat. It's not known yet, and there are many stages, many steps that have to go through. For instance, the retinoic acid receptor gamma agonists have been used in clinical trials to try to treat emphysema. It works in rats with emphysema. It doesn't work very well in humans, but the importance of that is that all the toxicity trials have already been done in humans. In contrast, if you're going to go to something like the short interfering RNA, there's all sorts of toxicity trials in cells and animals before going to any clinical trials. So I don't know where they stand. I know that all the known cases of FOP have been sent questionnaires of their history of FOP, trying to get a natural history so that there's some sort of firm progression that we can point to. And just a few words about the transgenic mouse model. This is the hind foot of a normal mouse, and this is the equivalent of the great toe. And this is the transgenic mouse model of FOP, and you can see that the great toe is very short. And this is an X-ray showing the same thing. And if we look at an X-ray of the whole mouse, there's extra bone around this knee, extra bone there, extra bone there. The reason there are circles there is there is spinal fusion in these areas, similar to what humans with FOP has. There's extra bone here. And if we look at the various features that we see in FOP, the mouse model has all of those same features. This was just reported last year. So the advantage of having a true genetic model is it's an in vivo model where you can try different treatments and see whether or not they're effective before ever going to humans. It's better than cells. Now there is some research, basic research going on here. Ed Shao, who's an assistant professor in endocrinology here, is not only involved in the inpatient care of FOP patients, including the young lady who's in here now. He has a metabolic bone clinic, and he's seen a couple of patients with FOP already, and he's doing very interesting stem cell research. He, using the same methods that were developed by Dr. Yamanaka in Tokyo to produce induced pluripotent stem cells, they can take fibroblasts from adults. You don't have to use embryonic stem cells. And using 4 different factors, growing the cells and then treating the cells with 4 different factors, you can produce these stem cells, which then using different factors, you can differentiate, or they can differentiate into different cells. For instance, this is, the idea here is cardiac muscle that will contract, regular muscle, and mineralized. They can look at mineralization of tissue. They can grow these cells into different types of cells. And this is the result. He has some cells from people with FOP, and cells from people from FOP are obtained from the primary teeth that are shed by children. They can get cells out of those teeth, and then Ed is able to grow them. And these are induced pluripotent stem cells from an individual without FOP, and these are from an individual with FOP, and the black staining is bone mineral, indicating that these cells are producing much more bone mineral than these cells are. The other interesting thing he's told me is that when he's tried to make these stem cells turn into nerve cells, he has no trouble doing it from people without FOP, but he cannot get nerve cells to grow out of cells from people with FOP. Now, the last thing I want to talk about is the International FOP Association. This is Jeannie Pieper, who has FOP, and she was a patient. I mentioned Mike Zasloff earlier, the geneticist who led Fred Kaplan into studying FOP and being involved. Jeannie was a patient of Dr. Zasloff when he was at the NIH, and she had never met anyone with FOP, and she said, "Can you give me the addresses of some other of your patients so we can just sort of start communicating and help each other out?" Well, this grew into Jeannie grew this into the International FOP Association, and you all received a little bibliography, and there are two things in that bibliography I'd like to strongly recommend. One is the website, www.ifopa.org, and there's an enormous amount of information there. And the other is the article, "A Few Hundred People Turned to Bone," which was in the Atlantic about 15 years ago. It's a very interesting article, and you can the website to get the article is on the bibliography. This is Jeannie's sister, Jeannie's boyfriend, and Jeannie's mother. The International FOP now has more than 500 members. That's 500 members of the people with FOP in 50 countries. And they're having a 25th year reunion or celebration this month in Florida. The mission is to fund research to find a cure, support and education of individuals with FOP and their families, and increase public awareness and advocate for support of research. The funds from are from family fundraising events and donations, and this is the part that really impresses me. The IFOPA supports research at about $500,000 a year. This is a condition 1 in 2 million people. And this is 75% of the budget of the FOP laboratory at the University of Pennsylvania, and they have 2 NIH grants to support that lab, and yet 75% of their budget is from the IFOPA. Quite a remarkable group of people. And this is an example. This was a dinner in Santa Maria, sponsored by the Kiwanis Club and the Snow family putting it together. This is the young lady who's in hospital right now. This was taken a few years ago. This is her younger sister, who's now a student at Sonoma State, and her parents, Bob and Jennifer. They put on this dinner for 15 years. About 500 people go to the dinner, and then they have an auction of donated goods. And then in the spring, they put on a barbecue, 15 years of putting on a barbecue where they served 6,000 chicken dinners. And they've done this, and this is just one family. An example is quite a remarkable family doing it. But there are families throughout the country and actually throughout the world who put on these fundraisers so that the IFOPA can put out $500,000 a year to support research. And I went over those research advances. Most of them were at least partially funded by the International FOP Association. Okay, getting to the end, finally. Rare debilitating genetic disease, the malformation of the great toes, rapidly appearing tumor-like swellings that turn into bone, no effective treatment, research support through the IFOPA families, and hopefully there's going to be a clinical trial of treatment in the relatively near future. And the relatively near future probably means 2 or 3 or 4 years. Now, I'd like to open it for questions, but I want to do it a little bit differently. I'd like Matt to come forward. This is our grandson, Matt. And if you have questions, you can either ask me questions or you can ask Matt questions. Why don't you come up here, Matt? This is the only microphone we have, so he has to come up here. Is there anybody who has any questions? Yeah.
Yeah, what's the situation with osteoblasts and osteoclasts? And secondly, if it's a lymphocytic infiltrate, wouldn't immunosuppressants or anti-leukemia, anti-lymphoma drugs be tried and effective?
Yeah, I don't know what you mean. What's the situation with osteoblasts and osteoclasts? It's normal bone formation.
Normal bone.
Yeah, the osteoblasts and osteoclasts are normal. Everything that's been examined, it's just the wrong place at the wrong time. Otherwise, everything's normal. Yes, chemotherapy does not seem to be effective. Bone transplant, we know, is not effective. But immune suppressive drugs may be effective. There's one individual who had a bone transplant, I forget why he had it, and put on immune suppressants. And while he was on immune suppressants, his FOP was totally quiescent. When he stopped the immune suppressants, it flared up again. But we don't know the mechanism that it would affects it. It's clearly an immune process, and there are certainly potential severe side effects from immune suppressants. And so people have not jumped to that. Yes?
Is there any hypothesis for the fact that the pelvic connection to the thigh regrew but the young lady who had her chin disconnected from her chest did not regrow.
Well, one thing is they packed bone around there. The hypothesis, there was a great deal of discussion that went on before she was operated on. Also, the young lady I mentioned who's in hospital here, when she first was admitted here for her neurologic problems, she was having severe myoclonus. I've never seen anything like it. Her legs were banging together like this that couldn't be controlled. So, and she had a marked kyphosis, and her spinal cord, she had marked kyphosis with very sharp angle in her neck, and the spinal cord was over that, and we felt that was causing it, and that seemed to be the electrical focus. So we had a great discussion as to whether or not we could operate on her, and against Dr. Kaplan's advice, we went ahead, and we put her on high-dose steroids for several days, and what we were doing was the same thing they were doing. We were fusing the spine, and we didn't care if there was new bone formation. Straightened the spine. I shouldn't say we, it was the orthopedists and the neurosurgeons, but straightened the spine, and then fused the spine. And the same thing with that young girl. They fused it. But if you remove it somewhere else where you don't want it fused, you'd rather not fuse the leg, then you're going to get bone formation.
She's the one who presented 28 times?
Yeah, she's here her 29th time. It's for not just for FOP, it's for neurologic complications of FOP. Yes?
Matt, I was wondering, do you feel any pain at all when you're walking around?
Oh, pain? Yeah, it's kind of one of those things where it's not really painful. It's just your body can only take so much of it. So I can't walk long distances. Pain you kind of get used to after a while, but it's more of your body just kind of giving out on you. So it's not really pain related, but you kind of get used to that after a while. It's just more of your body, your muscles becoming so fatigued that they can't go on any farther, so.
Just sit down a minute. I'll turn this over if you've got more questions. Yes?
You said it's genetically, it's on the gene, so is it inherited from the parents, or how does it progress?
Almost every case is a new mutation. If you have the abnormal gene, you have FOP. It's not like, there's no carrier state. It's what's called an autosomal dominant. So if you have the gene, you have the condition. There are only 7 known families that are multi-generational, where either the father or the mother has FOP in the world. So yes, it can be inherited, but it's almost always a new mutation. And to me, that's what's surprising. There's the same incidence throughout the world, all races, all ethnic groups, and all geographic locations. Yes?
Is Matt's case unusual in that he played football and was really physically active for so long?
Well, I think that's a very good point. He went out for high school football, and you get banged around, and there's certainly trauma in football, and it didn't cause flare-ups. And when I'm sorry?
My hip surgery.
Oh, yeah, he just reminded me. You were 12? 13?
15.
Another feature of FOP is that they have the femur is a long straight bone, and then it has a neck that goes up to the hip joint. And people with FOP have a very thick femoral neck and a large head of the femur. And the acetabular's normal in size, and it looks like it might be dislocated, might be congenital dislocation. And actually, Matt had surgery for congenital hip problems. And he did not have flare-ups for that when he was 13. Something happened when he was 17. And why didn't it, when he had hip surgery, why didn't he have bone formation all over? When he played football, why didn't he? I don't know. When I talked to Jeannie Pieper, the lady who started the IFOPA, and mentioned Matt played football, she said, when I was a teenager, I used to play tackle football with the boys. And she got away with it for a while, too. Yes? The question was, do the malformations, the great toes, affect walking? Before you had your flare-ups, did you have trouble walking?
No, I always had hip problems, so I was more focused on my hips more than anything else, but the toes never seemed to be that big of a problem, so.
Question is, what intrigued Dr. Kaplan to make him stop being an orthopedic surgeon and become a molecular biologist? Seeing a child with FOP. For some reason, that affected him much more than seeing adults with FOP. And I think you'd have to talk to him about it, but that's what he says. He said it just struck him that seeing a child affected with this condition. Yes? The question was, a young woman came in with a marked flare-up of her arm, and it resolved. What I mean is that she had marked swelling, and it was a flare-up, an FOP flare-up, and with treatment, elevation, non-steroidal anti-inflammatory drugs, and high-dose steroids, the swelling went down. She has marked limitation, and it was very painful, a huge swollen arm, very painful. She has marked limitations. She was one of the young women in wheelchairs of that group picture that I showed you, and she was about 25 in that picture. Yes? The question is, what's the relationship of FOP research to other diseases? It has two relationships, probably three different relationships. One, it relates to other conditions where there's so-called heterotopic ossification or bone formation where it shouldn't be forming. For instance, in total hip replacement, there's quite often heterotopic bone. Surgery for total hip replacement, there's quite often heterotopic bone. Blast injuries in the war that lead to amputations quite often have heterotopic bone. There are numerous other conditions, so the research on stopping heterotopic bone formation in FOP could have marked implications for a variety of other diseases. Also, there's bone formation in cardiac valve disease, a variety of different things. And spinal cord injuries, yes, and brain injuries, yes. The question is, are there any steps being taken to try to document or really alert people to the possibility of FOP in a newborn and looking for the toe malformations? Yeah, we've discussed that at length in the IFOPA. And one thing we did was we sent out a flyer to all of the nurses. I'm blocking on the name, but it's an organization, a national organization of nurses, women's health, obstetrics, and neonatal nurses, and sent, I think, something like 15,000 flyers with information about the great toes and FOP and what FOP is. We have not sent it to pediatricians, and maybe that was a mistake, but my reason for not doing it and spending all that money is that my experience, personal and others, is that when pediatricians get flyers, they throw them out. Doctors just don't read flyers. And the aim has been more to educate people through medical articles, through lectures at postgraduate courses, and trying to get FOP into textbooks.
Because I was going to say, one of the problems to me would be, I suspect that when somebody comes in with a flare, nobody thinks to take off their shoes and look at their feet.
Exactly. I asked Matt's oncologist, did you look at his feet? You know, not criticizing him because I had never heard of FOP. And he says, I don't look at feet, I'm an oncologist, I look at tumors. And I presented FOP to the pediatric oncology group here. They didn't know about it. When he was presented at tumor board for the third time after the radiologist at Kaiser had made the diagnosis of FOP, of the 15 or 20 physicians in the room at tumor board, there was one person who'd ever heard of FOP. And this is a fairly major medical center. Yeah, well, I've been here since 1965. You know, I'm somewhat prejudiced as to what the place, but you know, it's the standard of care for FOP. Yes. As
far as exercising goes, just because of, they were saying, the fatigue and there's no trauma to the muscle, even if I walked around the block every day, that could still cause extreme trauma if I was not careful. I've had flare-ups in my hip, or my thigh, sorry, and that was because I bent down to pick up something without really thinking about it, not stretching out the muscle, and it ended up not really pulling the muscle, but a few weeks later, it caused a flare-up. So it's the only real exercise I know of that actually can kind of be considered exercise is, you know, maybe going to a swimming pool But that should be only at a care facility where someone could actually be there with you. And so it's all low impact. And even that is, as far as I know, is recommended very small amounts. Because even that, being in a swimming pool, low impact for a short amount of time, if it's done wrong, even once, can cause a lot of trauma. So that's just everything in small amounts and not really learning how to know your body's limits. Because if you go over it once, you can never get it back. So, but.
Yes, up there. The question is, are there other conditions that cause the toe malformations in an infant? Yes, there are, but they're pretty unusual. You can have just malformations of the toes that are not FOP. So you cannot make the diagnosis of FOP just on the basis of the toes, but you certainly can be alerted to the possibility and watch out and avoid trauma. And for instance, all babies get intramuscular injections of vitamin K when they're born to prevent hemorrhagic disease in the newborn. Should we stop that? We know that oral vitamin K is effective, but not as effective in preventing hemorrhagic disease as injections are. Should they not get immunizations? I have been in contact a few times with the National Immunization Advisory Board and spoken to several members, and this is not very high on their priority for the last few years. I can't get answers about which IM injections could be given subcutaneously for immunizations. And in fact, if you go to the IFOPA website, there's about an 80-page booklet you can download or you can read online, medical management of FOP. And there's a section in there on immunizations, and it's incomplete because we can't get the answers completely. But you can't make the diagnosis, but you could be alerted to the problem. But you know, if you think about it, how many hospitals have 2 million patients born there during the entire time they're open? We have about roughly 2,000 deliveries a year here. It turns out that Matt was born at Marin General, and another boy with FOP was also born at Marin General. That's quite remarkable. They're about 20 years apart in age, but yet, so it's so unusual, so rare that it's hard to get a lot of interest generated. Okay, well, thank you very much for your attention.